Thank you, everybody. Here we go. We're going to now talk about osteoarthritis, so treating of osteoarthritis. Where should we go next? Probably get into trouble for this, call me old-fashioned, but let's do ladies first. Kirsten, good afternoon, Kirsten. How are you?
I'm okay, thank you.
Brilliant. Everybody, meet Kirsten if you haven't already. Kirsten is a regular contributor for us on these webinars. Last month, worked alongside some of the other ACE Laser superstars with some case studies, and before that we heard from back in October we heard Kirsten on her own presenting about value to your practice and so forth, so that was a really good presentation too. So delighted that Kirsten has joined us again today. So Kirsten, over to you. You've got a case study on the knee, I believe.
I do, and despite having done this a few times now, I never get any less nervous as I know my time's approaching. And someday I will surprise everybody by having slides to back up my chat, but this is not that day. So I just have a quick presentation, really a case study around osteoarthritis of the knee. So the patient I'm going to speak about is a 70-year-old lady. I have been seeing her in my clinic for a number of years now. She comes in every couple of months for just routine treatment. She is a very active lady. She normally likes to, she plays badminton once a week. She's not been doing that recently, obviously, but in normal times, she likes to play badminton once a week. She goes out for lunch with her friends. She really enjoys walking, and she spends a lot of time in her garden. So she's a very active lady with quite a healthy social life normally. She also lives alone, so being able to carry on doing her activities and seeing her friends and being active is really important for her for kind of psychological reasons as well. So during a routine treatment, she mentioned to me that she had a long-standing history of knee pain. Her right knee had been sore for years. She told me that she had visited her GP and she had been referred for an x-ray, and that x-ray showed up just some osteoarthritic change associated with wear and tear, just from being such an active person and being 70 years old. Her pain wasn't bad enough to warrant her GP referring her onwards for any more invasive treatment, so she wasn't going to be considered for any form of surgical intervention or any form of injection therapy. It was just kind of put up with it until it gets worse and we can get you back in and look at doing something more substantial then. Her pain also wasn't enough to hold her back. She was kind of working through it and doing her usual activities, but she was quite uncomfortable in those things. There were certain things that set it off for her. So mostly when she bent her knee, she said the example she used was bending down to pick things up, that would kind of catch her. That's when she had her worst pain. And it was that she was wanting to kind of get on top of. So while she had been in the clinic for a routine treatment, she had spotted my marketing materials for my laser. So as anybody who has a laser will know, that when you get your free trial, you also get your big board. I was trying to think what the right word for that was, but I don't know, but it's a big board anyway. And you put leaflets in it. So I have that in my waiting area, and I have a smaller version of that in my clinic room. So she had her eye caught by that when she was visiting me for her routine treatment, and had wondered on the back of that if laser might be something that could help her out. So I gave her a leaflet, and during her routine treatment with me, we just had a chat about the laser and what it is and how it works, and what we'd be aiming for in treating her knee with that if she decided to go down that path. So I also told her that when you're treating osteoarthritis or things like that, where there's a physical change has happened there due to the wear and tear, we can't fix that. Like, the laser is not going to cure you of arthritis. I made it clear to her that the aim of the treatment would be to calm down inflammation, to reduce her pain, and therefore to increase her quality of movement. And as I always tell my patients, movement breeds movement, and that's what we want to achieve. We want to get that knee working better. So she was really keen to give it a go because, you know, it was having an effect on her life and she wanted to get on top of it. So we got her in. She had a total of 6 treatments. And if you have heard me speak before, you'll know that I tend to do my treatments once a week. Rather than kind of the 3-2-1 protocol. I just do 1 treatment a week for however many weeks the course may be. So in this case, it ended up being 6 weeks. The biggest difference that she noted was between her first and second treatments. So when she first saw me, her pain score was about a 6 to 7 out of 10 at those moments where it caught her. So when she was bending, she was about 6 to 7 out of 10. And after her first treatment, we managed to get that down to a 4 out of 10. So at her second session, she'd improved kind of by a good few points on kind of the pain score. So at her first treatment, what I had used was I used my global approach, utilising optical windows. And I know that there's going to be more on optical windows coming up soon, but just to kind of let you know what I'm speaking about, an optical window is when you look for the best way of getting light into an area, so the best way of applying the laser to get the light where you need it to go. When you're talking about a knee, you need to approach it from a few different angles to make sure that you hit all the areas that you need to hit. So what I did was a scan phase. So I used that around the knee and associated muscles. You could potentially be flipping the patient back and forth, but I just kind of did my best with the scan phase around the anterior knee and then up the back as best I could. And then I did the knee pain pathology phase. So there's 6 points on that and they're pointed out on the laser itself. So I did 4 on the anterior knee, then I got my patient to turn over onto our front and I did 2 on the back. So that we were hitting it from all the different angles. And then I used trigger points at the 10 hertz for 23 seconds at 50% for her. And we did a couple of those on the back of her knee and then I got her to turn over again and we hit the front of the knee with the trigger points also. And when she came back in for her second treatment and she'd had a pretty good result after her first, we just repeated that again. So we did use the same settings as we had done the first time. When she came in for her third appointment, which was obviously following her second treatment, she was still at a 4 out of 10. So while she was still better, we hadn't kind of progressed her past the 4 out of 10. So I had hoped for more than that for her. So I decided to kind of adjust the settings a little bit. So because we're talking about a chronic problems like higher frequencies, so I upped the frequency to about 1,500 hertz, and that was the only thing I adjusted. Everything else did the same protocols, the same areas. It was just the adjustment in the power that we were putting in there. And at her follow-up treatment after that, she was down to a 2 out of 10 from her pain score, and at her following treatments she stayed around that 2 out of 10. So she was absolutely delighted. I was absolutely delighted. You know, I think from a 6 to 7 out of 10 down to a 2 out of 10, it was a real game changer for her. And she said she was enjoying the fact that she could just do things without having to consider how she was going to move. You know, she wasn't going to get that really catchy pain when she bent her knee. So it did make things a lot easier for her. And she knows, I always say, if you feel that pain coming on again for any reason, you can come in for a top-up treatment. You know, you may just need a one-off or you might need a few. And she knows that option is there for her because, as we all know with arthritis, you know, it might be an ongoing kind of case of topping it up every now and again. So yeah, for her, it was very good.
Brilliant. Thank you, Kirsten. That's great. Where I come from, that's called a result.
Me too.
So brilliant. Thank you as always for sharing your one of your case studies there, one of your experiences there. So that's great, and thank you for your ongoing support. Brilliant. So stay with us. I'm sure people have some questions for you, which I'll keep towards the end. Thank you very much. You can relax now. That was great, thank you. Okay, we are now, next up is Jonathan Small. Most of you will know Jonathan, I'm sure. Jonathan, Health First Southam Foot and Gait Clinic, amongst other titles. Jonathan's going to share a case study with us today of the ankle, but delighted also, Jonathan's going to share a little bit about his experience of laser in general over his career in podiatry. So I'll let him tell you a little bit more about that. I'll jump straight over to Jonathan, and we're going to hear about a case study on the ankle and also a little bit more about Jonathan's experience with the lasers. Jonathan, how are you?
Yeah, good. Thank you, Steve. Thanks for inviting me.
Great. Absolutely my pleasure. Great to see you, and thank you ever so much. Over to you, sir.
Okay, I'm going to share my screen.
Oh, you're going to share the screen. Good luck.
Yeah.
I hope you do that better than I did.
Yeah, let's see. Can you guys see that?
We can indeed. I don't like show-offs.
Doesn't mean it works. Here we go. Okay.
Yeah, thank you.
So, I'm going to take you back 25 years. Okay, and this is what a laser therapy unit looked like 25 years ago. Way back then, I was diabetic foot specialist for the NHS. I was basically running the service by myself. I was the only podiatrist employed in that field. So I got all the diabetic foot ulcers at the hospital, and some of them didn't heal, as you can imagine. So a rep approached me about laser therapy. It was way before Steve's time. He may have been at Canterbury then, I don't know, but it was a long time ago. And they approached me and they said about laser therapy for ulcers. And I said, well, let me have a unit on trial, just the same way that Celtic SMR does at the moment. Let me have it on trial, and I'll try it with my diabetic foot ulcers. And it worked fantastically well, really, really good. Got ulcers healed that had been going on for a year with no real progress. Did a short course with the laser, and the ulcers responded and got to healed. Way back then in those sort of units, you had that single probe, and then you had this cluster probe as well. And so I applied to the NHS, wrote a paper to support them purchasing the unit, which was about £2,000 back then, and just got turned down, point blank. They weren't going to fund something that was going to save them money, and so we didn't get a laser unit in the NHS. Yet I'd had the success with all sorts of ulcers. Now, this blank slide is for Paul's benefit, because he may want to put his blindfold on now, because there's some foot pictures now, Paul, gory foot pictures you may not like the look of. So we used to use them with neuropathic ulcers, ischemic ulcers and neuroischemic ulcers, and all of them responded well to having laser therapy, and I was convinced that it was the future, and I went on laser therapy courses, and Amiga Lasers were running courses on it, because I wanted to find out more about it. But then, after 8 years as diabetic foot specialist, I ended up getting sidetracked, and I went to there was a new facility opened up, a gait lab, within our trust, and they were able to buy all sorts of equipment, lots and lots of equipment. I have no idea how they get the funding for that doesn't save lives, but we couldn't get the funding for just one piece of equipment for the foot ulcers. Just a little story around some of that equipment. The main computer that we actually got for processing all the information in the gait lab was actually the same computer they used for processing the CGI for the Titanic movie all those years ago. And from there we even got to the point of writing a paper. I wrote this paper on the use of movement analysis. It'd been nice to have got to the stage of being able to write a good paper on the use of laser therapy in diabetic foot ulceration, but unfortunately I was then made redundant because they closed the service. They promoted me to such a specialist state they had no alternative viable appointment for me, so I was out on my ear. So I set up, I'd already got a bit of a sideline private practice, but I wasn't focusing on it because of the NHS work, but I just focused on my NHS career. And this is my clinic in a quiet market town in Warwickshire. And I got the normal problems that everybody gets in their clinics. You get ulcers, you get MSK problems, and you get verrucae. And I didn't have magic answers to them way back then. There was no thing that I could think, actually, I've got real confidence in this, helping these patients. Other than my experience of treating the ulcers and having access to cryo, then it was very limited, and my MSK knowledge. So I'm So I'm diploma in podiatric medicine. I'm not a BSc. So whilst I was state registered, we didn't have a lot of MSK input in our training. Biomechanics in the 1980s was a very complex thing for people to explain to undergraduates, and it wasn't communicated very well at all. So MSK knowledge just wasn't great at the time. So I looked at what magic I could invest in, and the only thing around then was ultrasound units. That was the thing that physios were using, but I hadn't heard such great results with it, and certainly there was no use on ulcers or verrucae. So I thought that's no point. I need to look at the low-level laser therapy again. I knew that it could be used in MSK. I hadn't used it myself. I knew that it could be used for verrucae, and I hadn't used it at all. So I thought I'll give it a go. And I thought that would transform my practice, and oh boy, it didn't. The results were very hit and miss. Some great anecdotal stories. I got in touch with 10 verruca patients that hadn't resolved with cryo or strong acids, and I got them to ask them if they wanted to have a course of laser therapy. I got 10 of them in a course of 6 treatments over 6 weeks. First patient I reviewed a month later, he'd had his verruca the size of 250p coins. He'd had it for 20 years and it had gone. And that convinced me that, that laser therapy had made a difference to it. But over the course of the 10 patients, only 3 of them resolved with laser therapy. So, and that kind of reflected in all the conditions, the MSK treatments that I did. The only thing it didn't reflect was ulcers, and I dealt with ulcers that got much higher success levels. So it wasn't my holy grail, unfortunately. So I got down the line of shockwave therapy, and I bought a really good top range shockwave therapy. These are still available at the moment, £15,000 they are now. I didn't pay that much. I managed to get a good deal at half that price, thankfully, and started using that. But of course, that was more MSK based, and results are okay, but patients not too tolerant of it. So, Steve and I go back a long way in our years. And when he heard that I bought this was the look I got from him. He was not happy. He'd already been talking to me about laser. He said, "What are you doing getting that?" So after not too many conversations, actually, it didn't take a lot of persuading, because I'm still looking for that holy grail that will make a massive difference in practice. On the 6th of March 2019, he lent me a laser unit, and it arrived at my clinic. That put a smile on Steve's face, so it was worth it just to do that. So the first thing that happened was Paul came along, and he said with his training, said, "Anybody got any MSK issues?" Which I got a shoulder problem, and my wife had a shoulder problem. So he let loose on the laser into part of the training on the shoulder problem, and I'd had that problem for, I don't know, 8 months or something like that at the time. And and that evening, after he'd done what he was doing, my shoulder hurt. It was really, really sore. I knew something had happened. And then the next morning I woke up and I had no pain. And I've been in pain for 8 months, just a low background pain. And so I got using it on my wife's shoulder problem. And a friend had a shoulder problem, so I used it on there. And as a result of the shoulder programs on the device, it convinced me that there's something happening, something doing really well with the laser. So I started shouting about it to everybody, to all podiatrists. And I'm so pleased that the momentum has grown now, and Steve's got so many ACER superstars out there as a result of just going all that way back in time to my shoulder problem that actually resolved with Paul's work with the laser. So this is it. This is me in my clinic. You see the laser unit just on the left-hand side, pride of place, ready to hand if needs be. But the way I use it isn't used on every patient. It's offered as a treatment option. It's not a treatment option in the same way shockwave wouldn't be a treatment option, or injection therapy or whatever. It's offered, and then for the patient to choose what they're going to do. But when they do choose it, then it leads to some amazing reviews, and we all know the value of reviews in our practices. If you've not got reviews going on your websites, on your Facebook, on Google, then you need to be on it. It's the word of mouth for your business, and people will search for keywords, and if those keywords show up in your reviews, then you're going to get the higher exposure, and then potentially connect with you and come and see you. So having anything that that helps to get the message across that you can help your patients is really really worthwhile, and these are just a couple of excellent reviews as a result of offering laser therapy. So I want to go on to this this case study that Steve's asked me to talk about, and it's about ankle arthritis. Now, I'd like to say this was the X-ray of the patient, but it isn't. But from the history and from the experience, I would imagine that's exactly what it was, what it looked like inside. Because this was a female who presented, 38 years old. She'd lived on farm, and horse riding really was her life, and looking after a sheep. No medical problems, but she got a history of left ankle operations. She said for cartilage problems. She'd had a steroid injection to the right ankle, and she didn't mention anything specifically more about the left, other than the surgery. But she presented to me 6 months later, after I'd had my laser unit, complaining of serious pain now, especially on the left, affecting her walking and struggling to ride her horses. And her expectation, after 20 years of ankle operations, was to walk without pain. So the pressure's on, isn't it, when they come with this sort of history? Having a look at her, she had a reduced range of motion with pain on movement around the ankle and subtalar joints. She had an antalgic gait and supinated feet. She was in a mess. I had no magic. If I hadn't got laser therapy, I had nothing really that I could do for her in my toolbox. So when we go through the NL-DOCAT, which is what I use, so it was pain in the ankle for years, and both medial and lateral malleolus specifically. She'd had it for years. She'd lived with the problem, and the pain was on and off, and it reached an 8 to 9 out of 10 at worst, with stopping her dead, with stabbing and shooting pains up her leg. She tried aspirin, ibuprofen, and gin. I thought gin was probably a good remedy at times, and she often gives way, and it leads to her falling. And when she's riding a horse, the position annoyed her in that often dorsiflex position. And she's tried prescribing pain relief medication, but knocked her out too much. She'd had an X-ray, a few years ago, which showed a slight fracture and been treated with a boot. She used various supports and footwear. So my own solution was to send her for surgical review. I knew that really probably triple arthrodesis was going to be her answer. She was at that stage. They'd mentioned it to her years ago, so she was already aware that that might be a thing. So we wrote to the doctor and asked him to do that. But I did suggest trying some conservative measures while she was on the waiting list for that, looking at orthotics and lasers. I also mentioned prolotherapy and CBD oil, anything to help this poor lady. So initially, on that first appointment, I said to keep using her Aircast A6 as much as possible. When she wasn't wearing them, then I gave her a lateral heel wedge for use in her boots, and then to add on an extra cushioned posted heel wedge after that. And I said I'd see her in 2 weeks' time. So the feedback on the 3rd of January, 2 weeks later, was the left ankle had been painful and it given way due to pain. She'd been referred to the NHS surgeon. She got quite a quick appointment, 17th of December. And but she felt she was getting on well with the cambion heel pants, but she hadn't used it in combination with the brace. So we talked about laser therapy, and she was happy for a course of 3. That's what I tend to do, is offer them 3 and see if we're making any difference to things for them. It gives them confidence. There's no, I don't think one-off treatments is giving anybody a fair chance. I know that Steve advocates 5 to 12, so I tell them it's advocated as 5 to 12, but we'll try 3 and see how it goes. And then we were going to review once she'd seen the surgeon. But she was also happy to be referred to a local MSK podiatrist, because I'm not an MSK podiatrist, I'm a general podiatrist, not too far away from me, about 10 miles away. Abid, who you've heard of, is certainly engaged with Celtic a lot doing their ultrasound courses. Unfortunately, I'm just down the road, so I referred her to him for possible prolotherapy injection, and he also does a lot with CBD oil. So it made sense to involve somebody else. She didn't end up going to see Abid for whatever reason, but when you hear the story, you'll see why she didn't need to. So we started the laser therapy, and back then the programs were very limited in the foot. It took a year of nagging Steve and Steve nagging Italy to get some more programs for the foot together. So so we took the foot arthritis. Fortunately, there was a foot arthritis one, so I did it on a medium patient size, a phenotype, and those were the settings. And I did it on the medial ankle and on the lateral ankle, because that was where she was saying she felt the pain. So really a week later, and the left ankle felt great for 4 days, no pain, but then has returned. So I repeated it, but I upped it to a large size, so so it basically increased the intensity and reduced the time a little bit. Week later, foot was doing great with laser until saw surgeon 2 days ago. Okay, he moved it around a lot, which aggravated it. Okay, and they planned to do the injection. But she said the laser had been so brilliant, and the ankle was still sore because of that movement by the surgeon. So we repeated it. I didn't know about the thought process of increasing frequencies and changing things, so I just stuck with it. The next time she came in a week later, ankle doing really well, managed whole week in much less pain. So we repeated it once more and said we'd review her after Christmas and the New Year. And she said the ankle has been pain-free since the last treatment. The only discomfort was on the left ankle, only on full dorsiflexion. So she'd had the transformation she wanted, and she was delighted. She was riding a horse. She was absolutely over the moon. And so I said, we'll leave it 3 to 4 weeks just before her planned steroid injection. She came on the 29th, 3 weeks later, and she had no pain from her feet at all. Through this stage, she had developed a hallux extensor tendinopathy, and I also lasered that as well. And so she wasn't just reflecting on the ankle at this point; she was reflecting on everything with her feet. We only had very mild tenderness palpable, so I started on a rehab program just to see if we could just help along those lines. We did talk about BPS aspects of pain. This lady had been in pain for 20 years and was quite scared of falling, so there was no real confidence. But she got back her confidence, and then we talked around that. And said to postpone the steroid injection. Let's just see what happens, okay? So what happened next? Well, Steve asked me to do this talk, is what happened next, because I didn't hear anything from her. And I've been trying to get hold of her since Steve asked me, so I could get some feedback to find out where we were at. Well, an hour ago, I managed to get hold of her and speak to her. And she went, not good. Okay. And I went, oh, why? And she went, I stupidly went and had the steroid injection. Now, I said, well, and what had happened? She'd postponed the appointment. And so a couple of months later, it had started to niggle her again. And she got worried that she'd fall out of the NHS system if she didn't go and have the steroid injection. Instead of phoning me and saying, can I have some more laser, she went down to the steroid injection, and it's all gone downhill for her since. So on the phone today, she said she's going to come back and have the laser, and she regrets completely that she just didn't get in touch with me the minute it started niggling again. Now that is a reflection on maybe I should have better follow-up things, but when you do work magic on someone and then they start to have a problem again, you think they'd just come back to where the magic had happened, but unfortunately she didn't. But hopefully she will come back. And interestingly, from my practice point of view, that patient actually spent £923 on that 5-week package of care, and that's the value of having good solutions, good tools in your toolbox to help your patients. Because all I had before laser was the referral to surgery. So to sum up, and this is a quote you can use, Steve. Okay, so very much for me is that nobody's had my laser unit off me. They're just not. It's the piece I'm gonna get away from the clinic when I retire. And if there's one thing that I take, and anybody who knows me who's talked to me about laser, it's the thing that I tell you. If you're considering shockwave and laser, get your laser first. Doesn't mean that shockwave isn't appropriate. I can certainly see that value in shockwave, but for me, it's you know, the laser covers so many things. The only thing is, why can't it do the verrucas? So thank you very much.
I told you before, there's tea tree oil for that. Thank you, Jonathan. That was amazing. So much content there. Thank you. And such great to see, I hate this phrase, the journey you've had with laser. But it is great to see that. So thank you ever so much. Really great to see that insight. And of course, great to see that example there as well. So really, really grateful to you for that. I've no doubt one or two people will ask me to see that presentation. So if we can share it, I'd be very grateful. Or if you want to edit it first in any way, if you need to, then do. But that'd be good. Can't thank you enough, Jonathan. Really, really grateful. Thank you. One or two questions coming in, but we'll keep them to the end because I'd like now to move on to Salvatore. Salvatore.
Eccomi.
Ciao.
Here I am. Ciao.
How are you?
I'm fine, thanks.
I know two Italian words.
You're
Ciao.
okay. Ciao.
Ciao.
How are you? Come stai? Are three.
Oh, I did say come stai. Ciao and ciao. Ciao, hello. Ciao, goodbye.
I try to share my screen.
Please do. Nice to see you, Salvatore. Thanks for joining us. I should have said to everybody a warm welcome from the UK to Salvatore in Italy.
Can you see it?
There we go. There you are.
Okay, yeah.
Everybody see that okay? Kirsten, I can see you on screen. You give me the thumbs up. Jonathan, thumbs up. See that all okay? Brilliant.
Good?
Yeah.
Okay.
Over to you, Salvatore. You're going to tell us a little bit more about osteoarthritis, treating the osteoarthritis in general. And Kirsten touched on the optical windows in her presentation, and you're going to elaborate on that for us too, aren't you?
Exactly. Okay. Hello, everybody. My name is Salvatore Germano. I'm a physiotherapist and I'm a consultant for ASA laser. In fact, I'm a clinical specialist for ASA. I've been using different kinds of devices of ASA for more than 10 years, not only MLS laser therapy, but also il-terapia, IROTT, MIS, and magnetotherapy. So today we will focus our attention on the application of MLS in osteoarthritis. We know that the patient with osteoarthritis has a lot of difficulty, in particular in the activity, the life, suffer of stiffness, the knee, the joint could have swelling. The patient suffered of pain the level of the knee. The patient has also walking difficulty. So, which is our aim like a physiotherapist? We can do different kind of treatment. And like a physiotherapist, I can suggest the weight reduction. I can teach some exercises to the patient to increase the strength, for example, of the quadriceps. And in particular, I want to work with MLS laser therapy. Why? Because I want to decrease the pain. I want to increase the range of motion, because we know that with this kind of laser, with MLS laser therapy, we are going to increase the range of motion of the patient, decrease the inflammation, and in particular, we are going to improve also the activity, the life of the patient. Why choose MLS laser therapy? A lot of study has shown that laser therapy can help us to decrease the degenerative process of the osteoarthritis. We can decrease the prostaglandin level. We are going to increase the protein level with a repairing effect. We have a direct action on the chondrocyte activity, and we work to improve the thickening of the cartilage. I want to underline also that we have a lot of study also in the website of ASA Laser, and we have a specific campus that is called ASA Campus, that is inside the University of Florence, where we do a lot of study, not only in vivo, but also in vitro. So, this to resume. I know that you know this, but also to underline the efficacy of MLS. We work directly on the inflammation. We want to decrease the pain. We want to obtain an anti-edema effect and a biostimulation effect. Remember that we work every time when we use MLS on the muscle, we work on the cell, we work on the vascular system, and we work on the nerve. On the muscle, because we, thanks to the increase of the MyoD and alpha-enolase protein and the PP1 protein, we work directly on the biostimulation of the muscle, of the damaged muscle fiber. We work also to increase the range of movement, because we have a decrease of the viscoelasticity of the muscle fiber, in particular thanks to the photothermal effect, and we can increase the muscle contraction of the fiber of actina and the myosina. We work directly on the cell because we increase the activity of the ATP, and we work also on the vascular system because we are going to promote the angiogenesis, and in particular we are going to work on the nerve fibers, because thanks to the increase a specific protein that is called HNRNPK, we work on the restoration of the damaged fibers. Before I have listened very interesting speeches, and every time we speak about the decrease of pain. Why this? Because every time that we use MLS laser therapy, we have an increase of a specific protein that is called NLRP10 that works directly on the anti-inflammatory chain, and we have a block of the production of the interleukin. If you want, we can share you, I can send it to Steve, this very long study that was long more than 2 years, that is very, very interesting also to read.
Brilliant, thank you.
Welcome. Which are the benefits and the advantages? First of all, is not painful for the patient. The patient don't feel any kind of sensation during our therapy. It's not traumatic. We can think to the shockwave, for example. So it's totally pain-free, is not traumatic, and there are no side effects for the patient. We can consider it for a conservative treatment to postpone the implant of surgery, because we work on the anti-edema effect, and we work to decrease what I told you before, decrease the pain and increase the activity of the life of the patient. But we can use also immediately after the surgery, because we can reduce the edema and increase the microcirculation. We work directly on the post-operative scar. Okay, we can decrease the fibrosis of the scar. Remember also this, that thanks to the photomechanical effect, we have an increase of the production of the collagen. And we have a reduction of the inflammation, swelling, and bruising due to the injury or the surgery. And we speed up the rehabilitation plan. I suggest you every time to combine MLS laser therapy in combination with your specific activity of physiotherapist. And remember that we can use MLS also on the implant of last generation that are made, for example, in platinum or in titanium, without any kind of risk for the patient. What I suggest and how I suggest to you to use MLS in this kind of patients that are chronic. Usually we suggest to use from 8 to 12 maximum session. How many times in a week? In my clinic, I prefer treat the patient with this kind of pathology daily, but not less than 4 times in a week. And each session we know is very, very short, from 4 to 6, maximum 10 minutes, no more. And we can suggest to the patient to repeat the maintenance program 2 times in a year, for example, every 6 months. Every time we remember to do the global approach when we work, so don't focus the attention on the point of pain, but work all around the joint that we are going to treat. But in a specific way, we have to work for the osteoarthritis on the optical window. And what is the optical window? You know it, but it's that small area between one bone and the other bone that I must open to enter with the light of the laser inside the tissues. And we know that the light of this laser can arrive at a penetration depth of 4 centimeters, because we have the lowest absorption of the 3 chromophores that are the melanin, hemoglobin, and water, and we can arrive at this kind of penetration depth. When we work on the knee, we have to work on the 6th optical window. The first 2, the patient is face up, and we ask a flexion of the leg at 90 degrees, so we can work on the femorotibial joint in the medial and the lateral part. The third photo, the patient is face down, and we work every time on the femorotibial joint in the posterior path, medially and laterally. And the last 2, the patient is face up, and we do a shift with the thumb on the patella. If we do the shift laterally, we open the medial part of the femoral patellar joint, and vice versa. If we do the shift medially, we open the laterally part. To clarify better this concept, if you have them 6 or the Charlie, we can, this is a video. Okay, it doesn't work, sorry. I don't know why, but it doesn't work. But this is a video that with them 6, that where we can do the global approach for the knee. Okay, so we can, before working in a specific way on the optical window, we can do this kind of work on the knee. The other, I hope that this video is, okay, this works, perfect. This is how I work on the optical window. I ask to the patient to put the leg at 90 degrees, and I go and I find the femoral tibial joint in the medial way, and in this specific case, I work in a steady, in a fixed point. This is only a video, is not a real demonstration, only to show you where are the optical windows of the knee. In fact, the treatment is very, very fast. I do the shift with the thumb. I open the femoral patellar path in the medial part, and I work steady. Remember, every time when we use the handpiece, I have to work with the handpiece at 90 degrees to increase the absorption of the light of the laser. In this way, I do the shift medially, and I open the laterally optical window. The same work, we can do it how in scanning phase. So I search the optical window and I push the button and I begin the treatment. This is the, we already, sorry, was the other one, is this one. Okay, and I do the treatment in scanning. Okay, so we can choose which one, and after I will tell you which is my favorite treatment and why. So we do the same thing, and we can working steady, and we can working in scanning. The same is for with the patient face down, and I work on the posterior femorotibial joint in the laterally and the medially part every time, or also in this time, or steady, or in a scanning modality. This is an example how to select, you know this, but I prefer we select gonarthrosis. And when we use this kind of protocol, look at, I have the 6 points of treatment. So the software tell me how many points I have to use, and I have a certain amount of joule. When I use when I work with this kind of patient, I every time work with the 808, that is every time in a continuous interrupted emission, I select continuous pulsed wavelength. That means that it works in continuous. So I increase the total joule, is the double, okay? And I give more energy for this kind of patient that are in a chronic condition. The same is for the scan phase. I select gonarthrosis. I select scan phase. These are the 6 points. Okay. The same is scan phase. I select chronic, and I have more than 100 joule. I select CPW, so I'm going to work with the 808 in continuous admission, and I have increase, and I have more than 200 joule. I can start to work my work. Why? Which modality I prefer? I prefer the first one, steady, point by point. Why? Because I know exactly how many joule I'm using for a specific point. I can work steady without any kind of risk for the patient, and the software, this is an example of another pathology, but it's the same for the gonarthrosis. I know exactly how many joule I'm using specific for that point. If I work is scanning, I know that for a certain area, I'm going to use an amount of joule. Okay, I have finished.
Brilliant. I'm just replying to a question. Salvatore, thank you so much. That was amazing. That was brilliant. Thank you. There you go. There's your screensaver now.
Sorry,
that looks like a fun holiday and a beautiful family.
Oh, many thanks. I want to. Okay.
Was that where you live?
This is where I'd like to live, but okay. I have to share the. I want to stop, but I'm not able to. Wait, because no. Interrompi condivisione. Okay. Okay, perfect.
Awesome. Salvatore, so grateful to you. Thank you very much. Paul, Jenny, Jonathan, Kirsten, I know you need to get off shortly, so I won't put you on the spot to ask any questions, but you got any questions direct for Salvatore you'd like to come and have a chat with him about? Any on that, anything specifically? Or I will refer to the questions that I've got on chat, but anyone want to jump in? Paul, what's your thoughts?
What I generally do is exactly what Salvatore says regarding using the CPW. When I speak to people about this, I say we have to be very careful about using the CPW, because it's a little tool which we can use to actually increase the power, and in much more chronic situations we can use it. The settings which ACell laser give you are generally more on the acute, subacute areas. However, I tell patients the one person I deal with straight away on CPW, generally without even worrying about any rebound effect, is in the knee patients with you know, it's not osteoarthritis, it's an osteoarthrosis. We have a degenerative whole system here. They generally had this for years and years, and what I do is I just go in straight away with the CPW, and it's the one time I'm not worried at all about getting a rebound effect, because it is so chronic. This is what it needs. And sometimes people, they're a bit worried. Don't always be too worried. They're a bit worried, so if they go in with too much power straight away, they will get a rebound effect. I pretty much guarantee you, if you've got somebody who's had, you know, bad knee pain for 5-6 years, you ain't gonna get a rebound effect. That's what they need. They need that continuous wave on the 808, and that will make the difference, because we're literally doubling the joules straight away, and because it's so chronic, that is what's needed. Would you agree, Salvatore?
Yeah, I totally agree. I want to only say one thing, that remember that we can have an osteoarthrosis, for example, of the knee, but of every kind of joint that is in chronic, but we can have also a reacutization, and that kind of chronic condition of the patient could be in an acute phase. So we have to be very, very good physiotherapist or doctor, what we want to understand this, because if we work with that kind of patient that is in chronic, but in the specific period is in acute, we have to work in acute, first of all, to decrease the acute inflammation. After, we can begin to work in CPW to decrease the other kind of problem that is in chronic. So I totally agree with you, and I want to say only this thing, Paul.
Yeah, and the only other thing I would add is on the especially with you podiatrists, and I bring this up to a lot of people, but a big problem podiatrists see is midfoot arthritis. Once again, very, very chronic midfoot arthritis. Now, and please correct me if I'm wrong, Salvatore, but on these settings on the machine, it's dealing largely, I think it's probably 1.87 joules per square centimeter, but it's dealing with 15 points, all the little interphalangeal joints. And when I'm dealing with the midfoot, I'm dealing with probably 8 points, and they're bigger joints. I want to get more power into them anyway. So what I do automatically is I will reduce the points to 8, and I'll go back to 5 minutes, because it will just bring it down to probably 2.5 minutes. I go back 5 minutes, and you'll see straight away we're going in on an acute setting, 3.5 joules per square centimeter. But then, if it's, you know, Mrs. Smith has had this for 5 years, and every day she can't really walk properly, that's chronic. And I'm going to probably then even CPW that as well. So I'll be up to 6-7 joules per square centimeter into that midfoot. So just be aware of the size of the joints they're talking about. On that foot arthritis, it is all tiny little interphalangeal joints. The midfoot, they're slightly bigger. And so take notes of that when you're setting it up.
For this kind of problem, I prefer work, for example, scanning. It's difficult that I work steady point by point, and I work a lot in dynamic, because I prefer do a sort of scanning modality and a mobilization of the foot during the treatment. For also the same approach I have with the, for example, with the plantar fasciitis, when he's in chronic, okay. For the first session, I prefer work in dynamic and not steady, point by point, and not steady. This is my approach for this kind of pathology. But in my personal opinion.
Yeah. Okay, thank you, Paul. Thank you, Salvatore, again. I'm just going to scan down and see if I've got any questions. I know I had a question earlier from Nav about the ulcers, so I was going to keep that till the end so we could stay on the osteoarthritis. So I haven't forgotten you, Nav. Let me just see if I had any other questions specific to OA. Any special consideration? Here are from Gareth. Thank you, Gareth. Any special consideration, 32-year-old female with medial knee, OA, and a history of juvenile RA. So anything else to consider when using the laser for that? Anybody want to take that? Paul or Salvatore, maybe?
Juvenile what?
RA.
Oh, when we've got any rheumatoid arthritis, I remember Salvatore when he was in my clinic once, when we had psoriatic arthritis, and it's another machine. But again, calming these things down, we used the magnetotherapy first for 30 minutes on very low hertz, but quite high intensity. And then we went straight in with the foot arthritis. I would, you know, I wouldn't have any concerns about using that. I would probably want to be careful about putting too much power in straight away, just using the laser. But with the magnetotherapy and then the laser afterwards, we had a pretty miraculous change immediately.
Yes, I agree. We are going to decrease better the inflammation if we can use both in the same time. And in particular, when we work on a joint like a knee or a joint, for example, I use it, for example, when I have to treat the hip. I use a lot of, very often in combination magnetotherapy. I use it with very low frequency and very low intensity, and immediately after I do the MLS laser therapy. And we have a decrease of immediately of the pain after more respect only with the laser, but if you use it in combination, you have a decrease of pain more than only with the laser.
Thank you. Got a question here. Is it safe to use the laser alongside intra-articular injections? Thank you, Jenny.
Well, no, is the answer. Well, it's not safe, but if you've had, let's say, a corticosteroid injection in there, the laser, again, Salvatore, please help me on this one, but what the corticosteroid is doing is it's reducing inflammation, which the laser will do anyway. But what the corticosteroid actually does is actually stop the healing process. It halts it completely. And that's why I always tell people, just don't have the corticosteroid injection. You probably most likely will get a short-term pain reduction because you're actually hitting the prostaglandins hugely and you reduce pain. But what you're doing is, it's a superficial plaster. You actually halting the healing process within the tissues. What the laser's doing is reducing the inflammation, but it's actually also activating the cellular activity and repairing the tissues as well. If you want any injection in, people are amazing. If they want an injection, have a saline injection in there. But the corticosteroid is actually literally halting that healing process. And actually, that's interesting because going back to Jonathan's situation, she wants to come back. She's going to have to wait 6 weeks after the injection before he can start the laser again and get her right, which he will do. But because the 6 weeks period is really when the whole healing process has been stopped by the corticosteroid injection.
Well, she'll be okay because she was injected way back March time, March.
Fine,
April.
fine. Yeah, good.
I told her to get in as soon as she can.
Yeah, yeah.
Let's go to Nav's question. And I don't think I've missed any on the OA. So let me find Nav's question about ulcers. Are lasers good for all ulcers, such as venous ulcers or ischemic ones? Salvatore?
Yeah, we can use it, laser therapy, MLS, for increase the biostimulation of the tissues. There is a specific program in the software that is called the biostimulation, where we can treat different kind of ulcers. We have very good result with actinic ulcers, venous ulcers, and post-surgery ulcers. Lesser results with arterial ulcers because are very difficult ulcers to treat, and we have good results with the diabetic ulcers. But in this case, we have to the patient. We can help the patient because the patient has to resolve a pathology that is systemic. Remember this, that we have a correct biostimulation of the tissues around an amount of joule from 1 to 4. If we are going to use less than 1 joule, we have enough power, enough joule, and so we don't arrive to increase and obtain a biostimulation effect. And vice versa, if we go over 4 joule, we give more energy, and in this case we have a rebound effect. So if we use the parameter of biostimulation that I think that is 1500 Hertz, 8 minutes, 75% of intensity, we are going to use 2.9 joule per centimeter square. So in this way, I think without changing the area, in my personal opinion, you can treat not only the wounds, but also remember to treat the area that is all around the wounds. This is important to increase the photothermal effect, increase the microcirculation, increase the activity of the protein, increase the activity of the collagen, and in particular, and I want to underline this, that remember that if you are going to treat an ulcer with infection, if the patient is not taking antibiotics, we must not treat the patient. We can treat the patient only if the patient is taking antibiotics, because remember that infection is a contraindication. Okay, so every time you can use MLS also in association. For example, in my clinic we use it also in association with bandages, but you can use it to increase the biostimulation of the ulcers. If you have the Charlie or the M6 with the robotic head, if you use the biostimulation program, you are going to use around, I think you are around 9 joule per centimeter square, and you have to decrease the time to obtain an amount of joule from 1 to 4.
Brilliant, thank you. Some great points there, Salvatore. Thank you very much. So Amanda, has a question. We've got a 16-year-old post-surgery osteochondroma removal. I hope I've said that correctly. Is it safe to use a laser for the wound healing and inflammation for that patient?
Remember that another contraindication is the cancer. So the patient must not have an active cancer active cancer where we are doing the treatment. In particular, the patient must not have metastasis around the body. If the patient has a melanoma in the shoulder without metastasis, we can treat the lower limb, for example. But this could be a contraindication. For the age is not a problem. We can treat it. Remember that we have not to treat the growth center of the patient. This is the only precaution that we have to and pay attention only to this.
Brilliant, thank you. Amanda's actually come back and said non-cancerous, so thank you, Salvatore. I think that's covered. Hope that answered your question,
So
Amanda.
she can use the MLS without any kind of problem.